So we all know that lasers in ophthalmology has got a lot of indications in the anterior segment as well as various posterior segment pathologies. Oh my God! Excuse me, something is. Some. Yeah. Okay. So various posterior segment, most common posterior segment indications being diabetic retinopathy, BRVO, CRVO, ROP, ocular ischemic syndrome, and other neovascularizations caused by autoimmune disorders, infections, CSR, choroidal hemangioma, IPCV, and various other miscellaneous indications for laser. So the most common indication for laser photocoagulation for many decades being diabetic retinopathy, which is diabetic macular edema and proliferative diabetic retinopathy, are the two sight-threatening lesions treated by laser photocoagulation. Any thickening within 2 disc diameters in the center of the fovea is called DME, and laser photocoagulation was the only treatment of choice that was available for many decades. Unknown laser was not applied to all cases of DME and is applied to only cases with CSME. But the disadvantages of laser was around 30% of CSME cases had center-involved macular edema to which laser cannot be applied in the center of the fovea. Extensive laser photocoagulation causes scotoma, and despite a good focal laser, 50% of them used to have moderate visual loss. So there was a search for an alternative treatment. So the search came in the form of either anti-VEGF or the steroid. And in this era, now the classification of DME has changed into center-involved DME or non-center involved DME. So in non-center involved DME, still focal laser is the treatment of choice, and center involved in center involved DME, intravitreal injections is the treatment of choice now. So before the intravitreal injection era, it was focal laser only for DME. For any DME, even if it's CME, then we used to do extrafoveal laser only. But if it's center-involved DME, now we treat them with anti-VEGFs or steroids, a supplemental laser if there is a recurrence. So if it is in proliferative diabetic retinopathy, we all know that high-risk proliferative diabetic retinopathy, 1/4 disc new vessels, or any NVE with pre-retinal hemorrhage, or any NVD NVE with vitreous hemorrhage, then we do pan-retinal photocoagulation. And we all know that the area that is applied is leaving the macular area. The rest of the mid-peripheral retina we used to do in single sitting in mild scatter, or we do with in 2 sittings as advised in ETDRS, or nowadays we do in 3 sittings to avoid complications. A list of complications are available for this. So even today for high-risk proliferative diabetic retinopathy, we do pan-retinal photocoagulation as the first line treatment. But there are a lot of side effects of laser photocoagulation, so there is a search for an alternative treatment. To answer this, DRCR net has done protocol S, which has changed the management little bit. Ranibizumab, which was an anti-VEGF, was compared with a deferred laser without doing a pan-retinal photocoagulation. If you just treat with the primary ranibizumab, the mean change in visual acuity from baseline to 2 years was no worse than with the PRP, and visual acuity under curve was more superior, and visual field outcomes, less number of chances of vitrectomy, decreased chance of developing DME, and rarely PRP was required. So you can treat proliferative diabetic retinopathy primarily with anti-VEGF only without doing also laser photocoagulation. But the catch is, which is the deciding factor? The deciding factor is the presence or absence of DME. The DRCR net itself has shown that if there is DME is present with highly proliferative diabetic, the preference is to treat with anti-VEGF, or you can add laser after that. Or if the DME is not present, then you have to consider the cost of the treatment, the number of injections, follow-up, compliance, all the important factors in that. So the take-home message is, if you have a high-risk proliferative diabetic retinopathy without DME, then go for pan-retinal photocoagulation. High-risk proliferative diabetic with non-center involved DME, still you can do focal laser and PRP. If high-risk proliferative diabetic with center involved DME is there, then treat with anti-VEGFs. Once the DME subsides, or if neovasculation persists or recurs, then add laser. It is always safer, and don't go only with anti-VEGF, because if the patient is lost for follow-up, then he might land up with severe anterior segment neovasculation also. Next most common indication of laser in our thing is BRVO. For decades, the BRVO management was decided by BRVO study, which told that if you have a fresh BRVO, branch retinal vein occlusion, wait for 3 months for the retinal hemorrhages to clear, do an angiogram. If there is no macular ischemia, then do focal laser for the edema. If there is macular ischemia, then don't do any treatment. That was a recommendation. But the major setback is if you wait for the 3 months itself, it produces irreversible damage. And if ischemia is there is no option for that. So now array of studies have been done with anti-VEGFs starting from 2010 to 2015, and now we primarily treat BRVO with anti-VEGF every 3 monthly loading dose if needed till the macular edema subsides, and then PRN whenever the macular edema recurs, the vision decreases, we treat them with either anti-VEGF or a steroid implant. We can add supplemental grid laser in few cases of macular edema in macular BRVO, means only macular BRVO is there. You have to add a sectoral panretinal photocoagulation if you have new vessels over the disc or new vessels elsewhere to reduce the number of anti-VEGF injections in the management of BRVO. CRVO, again the guidelines were for many decades is CRVO study only. There is no role for laser photocoagulation macular edema, but tragically the most common cause for vision loss in CRVO is macular edema. So CRVO study has not answered that, and there is no role for laser. Then when you do laser, laser is when you have any new vessel at the angle or NVA of more than 2 clock hours or any NVD or NVE, then you do laser. Basically the laser in CRVO study is to prevent neovascular glaucoma. It's not going to improve the visual acuity. But the whole array of RCTs in anti-VEGF have clearly shown that the visual acuity, there will be improvement in case of CRVO if you treat with anti-VEGF. So there is no role of laser photocoagulation in CRVO management, primarily treated with anti-VEGF or steroid implants, and PRP is applied only as a salvage in extreme cases to prevent neovascular glaucoma. And in ROP we all know that laser photocoagulation is the first treatment of choice if it is a threshold ROP or an anterior disease. But if you have a very posterior disease, aggressive ROP or a posterior disease, then treat with anti-VEGF and add a supplemental laser once the ischemia persists in the anterior part of the retina. So there is a mix. You have a role of laser as a primary treatment, as well as you can treat if it is a posterior disease with an anti-VEGF. In an ocular ischemic syndrome, if we have, I'll just take a couple of slides. Only NVA or NVA, no neovascular glaucoma. If NVA neovascular glaucoma is there, then treat with anti-VEGF. So other indications, laser photocoagulation is the treatment of choice, and many of them don't need an anti-VEGF treatment. Like in a CSR, it is a focal laser for a single leak, or if you have a subfoveal leak, then treat with TTT or PTT. If an IPCV, only if you have a very extrafoveal polyp or CNVM, then treat with laser, otherwise anti-VEGF. RAM, direct focal laser, retinal tears, only laser. So to summarize, laser photocoagulation is still will exist in the treatment of retina for the decades to come. So please learn the technique properly, and it is used in supplementary treatment or adjuvant treatment, or in some cases primary treatment. Thank you.
Okay. Thank you, Chandramohan, for that exciting talk in era of VEGFs. But one question I want to ask, you said PDR with DME, center involving, you said injections, not laser. Why?
No, sir. Injections, definitely laser to be added, sir. Laser should not be neglected.
No. Why?
No, as a primary, sir, anti-VEGF addresses both diabetic macular edema as well as neovascularization. So if you treat diabetic macular edema according to protocol, like 3 to 6 loading doses, and then follow the patient, there are many of the cases the PDR neovascularization also regresses. But still, you have to treat the PDR neovascularization carefully. And I personally in my practice, I treat DME with anti-VEGF. Once the DME subsides, then I do panretinal photocoagulation.
Yes. I want an answer that if you do the laser without anti-VEGFs, when DME is prominent, it worsens. Can worsen.
Yes.
Okay.
Yes.
Youngsters probably not knowing that. I want to bring out that
point.
you.
Yes.
So if you are doing laser, there will be a
aggravation
post-laser aggravation or worsening of the diabetic macular edema. So you need to assess clinically whether it is going to benefit or it will worsen the situation. If that is assessed and if there is a high risk of worsening, you go for anti-VEGFs. Otherwise, there is a clear set away from the center DME, still you can do only laser and get away.
with it.
Thank you. Right, now we will call upon Dr. Arvind Maurya. He will be speaking on development of smartphone annotation tool for faster and accurate image labeling AI for common retinal disorders. Means it is so long, so
Yeah, yeah.
with the length of the title, I need to slow down a little bit.
Good morning,
Okay,
everyone.
Arvind.
Yeah. Thank you, sir. Thank you
He's
so
an
very much.
exciting guy from AIMS Hyderabad, and he's a lot of enthusiastic, and he will listen. He's an exciting personality as such. Arvind,
Good morning, my dear friends, and thank you,
you need to
AIOS, for
change
giving
this photograph, Arvind.
giving me the opportunity. Sir, I will change it. So my talk is on development of the world's first smartphone annotation tool for faster and accurate image labeling for AI-based grading in common retinal disorders. So as we all know that deep learning and AI have become widespread because of the availability of large digital data, and supervised learning algorithms have shown human level performance. And to get huge data set with good quality control, there is a need of an annotation tool with a customizable feature set. And this multi-centric study evaluated the viability of having an in-house annotation tool which work on a smartphone and can be used in a healthcare setting. So as we all know that diabetic retinopathy and other retinal disorders, there are 425 million people worldwide they are diabetic, and 70 million suffering from glaucoma and 20 million from ARMD. So they require better screening by the community ophthalmologists for early prevention and for risk evaluation, especially in the remotest of the area and especially in the COVID era. So what are the disadvantages of the existing desktop-based applications for annotation? They are not mobile, and the progress of graders can't be supervised, loss of data because of hardware issue, no data exchange for offline mode, and loss of annotations because of poor network. So the objectives of this tool were quantify the amount of damage already done and segmentation of lesions like the exudate, microaneurysm, and any vascular abnormalities. And at present, IDX DR by M. Abramov is the only US FDA approved AI-based equipment, but it is very bulky and very expensive. So we followed the ICDR severity disease scale, none, mild, moderate, severe, and PDR bucketed with moderate or severe NPDR, PDR, and or macular edema as referable diabetic retinopathy. And we followed the binary module based on the convolutional neural network deep learning algorithm for the other referable retinal disease and non-referable retinal disease. So it begins with 32 retinal specialists in India along with 8 IIT engineers. We started with an online tool label box for labeling of publicly available data set to evaluate the need of a smartphone application. So these were the advantages. So we were able to grade multiple retinal images easily in a very short span of time. It was very user-friendly tool using user interface and user feedback. It was integrated with advanced testing and internal validation sets. It was faster, mobile. We were able to track the progress, and domain expert feedback was there for the graphic user interface. It has many special features like zoom capacity of 3 options of 512, 6, 768 and 1024 pixels capacity, green channel for the red free image, and we added the brightness and contrast slider. So there were 5% of images they were ungradable. So by using the brightness and contrast slider, we were able to grade those images also. And we followed the smart image preloading system. So it has a smarter image compression format that is known as WebP. It maintains resolution of images but keeping low memory footprints. So this is a small video. So this led us to develop our own in-house image annotation tool as seen in the video. Adding an annotation for an image is pretty easy. View the image, magnify it, change the brightness, change the contrast as needed, click on the relevant option, choose the extra details, and the annotation is saved. The analytics on the landing page show the pending and completed images. The graph shows the maximum number of images stacked by the other users in real time and gave the daily target settings. And these amazing data sets are generally in the range of thousands and can be overwhelming for a single surgeon. So we chunk them into sets and each containing 1000 images or less, which a grader can complete within 2 weeks quite easily. And the issues mentioned earlier were resolved as follows. For faster image loading, we resized images into smaller size thumbnails with a smaller memory footprint and still maintaining the visual quality. And we leveraged the asynchronous capabilities of the browser and didn't load just 1 but 3 images preemptively so that the grader doesn't need to wait for the next image to load. And the initial interface was basic and evolved based on the grader feedback. It is now designed on a decision tree structure to render the nested subclassification and extra options. And finally, we have seen a total behavioral change where on the online tools the grader used to work only on the weekend, but on our tool we have logged users on all days of the week. And the average time taken also reduced substantially. We validated the AI algorithm developed using annotations on this tool on some new testing data sets and found them to have a really high performance score. This strengthens our hypothesis that this tool is no different than the desktop based tools with added benefits of being portable and flexible. So the future uses stats after evaluating over 2 lakhs of retinal images. This is the highest worldwide data ever annotated and graded. So this confirms our hypothesis with high sensitivity. There are other 2 studies, APTOS. So as compared to those studies, it has high sensitivity and specificity. So now we are developing an offline smartphone application which can diagnose patients of common retinal disease in less than 5 minutes, 53 seconds to be exact, and very soon it will be available on Google Play Store. And this application hopefully will surely transform patient management and telemedicine in near future. Thank you so very much. Welcome, Dr. Gopal Pillai.
Yeah, he's the moderator. That's why I said you speak. He's right now gasping. So we will thank you very much, Maurya. And any questions for Dr. Arvind Maurya from the floor?
Meanwhile, can we have Dr. Sandeep Reddy?
Yeah.
Please be ready.
We have 2 speakers on the same topic. That wide field imaging. So Sandeep and Prashant, we will take the questions after your second talk. Sandeep, to introduce, he is from Tadepalli Gudem. It's not Gudem actually, it is a city, and there is a king. That king is called G.R. Reddy and his son is called Sandeep Reddy, but the prince is much efficient than the king. That's what I perceive him as, and he's very promising, and you will see Sandeep in limelight in future.
So
Arvind, thank you very much.
Thank you, AIOS, for giving me the opportunity. I'll be presenting a few pictures and the role of wide field photography and OCT angio in today's diabetic retinopathy. So the initial classification by ETDRS or the international classification, they've done the early classification where they have taken 7 photographs like this, and they have taken the montage, and this is the area that was being covered. So today the images are so wide that you can actually see more retina, and you can actually see the lesions even much more peripheral, and the pictures which they have used initially did not cover the most of the peripheral retina. So I think this itself lays the platform for us to understand that wide field photography has to be replaced by the conventional photography, fundus photography. So just this international classification and the ETDRS classification of the various pictures of various lesions of the hemorrhages, venous bleeding, interretinal abnormalities. So when it comes to the wide field photography, it's something like this, where you can see few hemorrhages can be classified as mild NPDR, and there are few cotton wool spots where you can grade it as a moderate NPDR. And this picture, when you look at a picture like this, one would say it is a kind of moderate NPDR or so, but when you actually see very close, you can see here there are ghost vessels seen, and there are venous bleeding. These kind of pictures actually, I mean the kind of photographies when you actually do, you can actually see the very subtle lesions, and there is a intraretinal microvascular abnormalities as seen here. So what I do generally is, when you see CNP areas, something like that, I believe in doing a selective PHC, not rather than the complete 360 PRP. That means selective PHC is you target the ischemic retina and do a photocoagulation, so that you don't destroy the healthy retina. So in cases like this, for example, this is also a severe NPDR. Only if you look at a picture like this, only in the central part there are not much of lesions to be seen. But if you actually see, there are venous beading that is extending almost in all almost 3 quadrants, and you can see there is a color differentiation here. So this color differentiation is because of the ischemic retina, where the choroid is much more prominent. So you can actually, by these photographs, you can actually evaluate there are peripheral ischemic retina even before the new vessels have actually appeared. So this was a case where on a routine 90-day examination, there are few hemorrhages seen here in the macular area. When the patient was little uncooperative, these kind of new vessels were so subtle that we actually generally tend to miss in a busy practice, like when you see a lot of patients in busy practice. But when you take a fundus picture and you can actually have the liberty of making an enlarged view, and you can actually see those new vessels. If you look at this picture here, there are absolutely no hemorrhages in the entire macular area, and the hemorrhages in the periphery are also very, very subtle. But if you actually take a wide field picture, it is almost an auto-regressing kind of PDR. And the role of in the same patient, when we have done OCT angio, you can actually see there are new vessels which are very subtle. The new vessels have been well demonstrated in the OCT angiography picture. So this is a case where there are hardly any hemorrhages anywhere. If you have only seen the macular area, it looks very healthy, but if you actually see, there is a periretinal bleed and there is a new vessels here. So it is a case of an early PDR. This is the is one more example of such a case. And these are the advanced PDR with the traction lateral detachment with the large fibrous band, and these are the to be treated as a surgically. And this is the it's a very good tool for us to explain to the patient also what kind of a condition the patient is coming in, and what could be the prognosis. So this is the patient where I have done a 360 degrees the 3 sessions of PRP laser, and then I have operated the patient. And after the surgery is done, when we take a fundus picture like this, you can still see there's some area which is unlasered. So it will help us to evaluate any unlasered areas, so that I could add some more laser post-operatively in these patients. So this is a patient where it looks very healthy. I mean, it's a very stable PDR, but you can actually see there are few fresh hemorrhages that are appearing in the retina. So you can also evaluate that the patient, even though the PDR looks well stabilized with the laser, and there is still some amount of progression that is happening. So this is also a patient where you can see there are a lot of skip areas in between, and the new vessels are not completely regressed. So you can evaluate the skip areas by taking a wide field picture, and you can add up lasers on all the ischemic areas. So this patient, again, the patient, you can actually see there are large ghost vessels in the macular area. So and there is also a vitreous hemorrhage which is obscuring your vision, but because of the good picture, you can actually see those ghost vessels, and you can actually say the patient has got macular ischemia. And some more examples where there are very subtle new vessels that can be seen, and you can actually advise them for photocoagulation. And this patient, there was a large space, then there's a gap area that was in left out, and you can clearly see there are venous beading and venous loops here, and this is all ischemic retina, where you can add up some more laser to stabilize the retina. And very similar patients where this wide field photography has helped us to add additional lasers to the ischemic retina. And here you can see there are large font of blood where new vessels have seen, and I have this guided me very well to do additional laser in such eyes. So this is a patient where the patient had a little pale disc and well thoroughly lasered retina. It looks very stable. The patient had about 6/18 vision, and he was complaining of recent drop of vision. He had multiple injections of anti-VEGFs, and when we did our OCT angio, you can see the macular.
Need to conclude.
Yes, sir. So the patient had a large CNP areas and had a large macular ischemia. I just want to add up, I want to show pictures where the microaneurysms, there are a lot of microaneurysms in the CSME which had helped us to do a focal laser. I just want to add up a few importance of OCT angiography in BR vivo. This is an ischemic BR vivo where it is well compensated. You can see collaterals developed inside. So these patients can be well followed even without a laser. So this is also ischemic BR vivo, well compensated. and this is a minor BRBO, well compensated. While this is a ischemic CRBO, in this picture when you have seen the completely you can actually see confidently can say by looking at OCT angiography that the patient has got an ischemic CRBO, you can straight away go with PRP laser. And these are large collaterals which are so difficult to evaluate an NTT examination. When you do a thorough good photography, you can actually see these are very large collaterals that the patient has developed in a BRBO case. So wide field photography and angiography, I would say they have changed the complete understanding of the disease as such, and you can customize your treatment as per the patient's disease state. Thank you.
Thank you, Sandeep. It's a very enlightening talk actually, and I want to point out a few things. That one, you said selective retinal photocoagulation.
Yes,
It's already called targeted retinal photocoagulation. This concept is very well existing, and you need to practice it more so that we can save the field in diabetics. That is number one. Second is the clinical suspicion of NVE. Whenever there is a blood and retinal hemorrhages, if the size is a little larger, you showed very clear pre-retinal hemorrhage, but always suspect neovascularization. Either you do OCT angio or FFA angiography and then confirm and then go ahead with the laser. Third is the fibrovascular proliferation. Whenever it is there, even if there is non-lasered areas, if the fibrosis is predominant and vasculature is less predominant, you can still observe very carefully. We need not photocoagulate a empty retina just because it is areas of non-photocoagulation are there. And the fourth point in your talk is there is a disc pallor, severe disc pallor in diabetic well lasered. It's usually because of the consecutive optic atrophy will be there, but you need to take help of your father and get the fields so that we can have what field is existing in that patient. That will help us. Okay, with this I think we will proceed with Prashant, and he's also almost same topic, but we'll deal with it later.
Thank you, sir. I would be skipping on the part like diabetic retinopathy and RVO, which Sandeep has very well elaborated the importance. Well, friends, it's a time of wide field OCT. Let's see, what is usually a standard OCT is about 9 to 12 millimeter. In a wide field, you get a width of about 16 millimeter slab. And so it can help you in picking up a simultaneous concomitantly existing simultaneous pathology at two places. For example, you can see a peripheral CSR with a PED in a single view. This is a RD versus retinoschisis. I will just share some of the cases from my end. This is 80 years old mother of a pathologist. This is the picture. She initially presented to us with a macular edema diagnosed elsewhere. But when you have a wide field photography, you can see there is a PCV large lesions in the periphery with some drusen in the central. And if you look at the OCT over here, you can see the fluid creeping in, but there is a large lesion of a peripheral PCV. And that was the reason why we could pick it up, and we did a wide field angio and OCT. And then importantly, in such a wide field OCT, you can actually compare the sequential for OCTs can show you the regression of the lesion as well as the macular fluid, how it is drying off. Utility in diabetic retinopathy, which Dr. Sandeep has highlighted, so I will just run through that slides, rather I have bypassed those slides. I will come to other cases where it can be used. This is 67 years old male who was diagnosed to have macular edema, was advised an anti-VEGF elsewhere. This is a standard routine OCT done. Yes, the diagnosis seems to be okay, but you do a wide field OCT, you can see the skytic cavities extending much more beyond the macula. So it was not a simple case of a macular edema, it was a case of a retinoschisis. But this patient had a progressive loss of vision. Why should have sudden onset of progressive loss of vision in a retinoschisis? There is a gradual loss is acceptable. So we did an angiogram for this wide field angiogram, and I will just come to the angiogram where you can see what you see is a telangiectatic response in the extreme periphery, much anterior to the equator. So this is a vascular response which you get in a case of a retinoschisis, which was responsible for superimposed edema in a case of a retinoschisis, and naturally we treated him with lasers and anti-VEGF as well. So now this is another patient who presented with partial retinal detachment, was advised vitreous surgery elsewhere, came for a second opinion. But when we looked at the other eye, we thought we are seeing some fibrous tissue here. We also thought we are seeing some fibrous tissue. You can see a beautiful wide field photograph, and we did an angiogram, and what do you notice? You had a FEVR in both the eyes. So importantly, what we did was we treated the better eye, which was asymptomatic, with lasers, and prevented and averted a disaster which had happened in the left eye. Of course, we did operate the left eye, did a vitreous surgery, but importantly, from wide field angiography, we could pick up a lesion which was in the extreme periphery. Now, this is 52 years old female who complained of floaters, and he was diagnosed to have epiretinal membrane and advised surgery. On a wide field photograph, you can well see that there is a pulling of the vessels and the macula appears ectopic. And this is how wide field photography helped us. And in fact, it was again a case of FEVR with VMT. So it was not simple vitrectomy with epiretinal membrane peeling to be done here. You had to do also treat the peripheral part with the lasers, and also we had to use this is a Ozurdex implant post-operatively which was placed. Now this is 48 years old male who had diagnosed to have rod spot, and this was the photograph angiogram which was available to him, which was not much contributing to our knowledge. But when we did a wide field angiography for this particular patient, you can see a terrific shutdown in the periphery, which cannot be picked up with a standard conventional photograph. And naturally, he needed an aggressive, and we went for systemic evaluation. He had a bilateral carotid disease. Now, another patient with this particular photograph was advised macular hole, OCT showed macular hole, was advised vitreous surgery for them. But importantly, when we did an angiogram, you could see a half zone disease. Half zone disease is a terminology to be used in a cases of ROP, but you can see in an elderly. And again, this patient was relatively evaluated. More importantly than doing vitreous surgery was to do a systemic evaluation, and we could pick up a systemic carotid disease even in this particular patient. This is 26 years old female girl, female who had a healed choroiditis, but he complained of progressive loss of vision. In a healed choroiditis, I was not able to understand what is happening. And that is the time we advised him with an angiogram. And as you can see on an angiogram, you can see a capillary non-perfusion in the periphery. So we had to do a wide field fluorescent angiography, revealed an ischemia simultaneous along in a case of a healed choroiditis. We treated the peripheral part with the lasers, and the patient's edema responded. Now this is 48 years old male who had vitreous hemorrhage secondary to choroiditis, and when we did a wide field angiogram, you can see the dropout classically in the extreme periphery. We did a peripheral laser for this patient, and we could do it, which cannot be done in a conventional angiograms. Now this is 25 years girl who was diagnosed elsewhere as ill disease in the left eye and advised vitreous surgery. And this was the fundus at presentation. Yes, we accepted, but when I looked into the left eye, I thought I am seeing something abnormal. This is what is called classic pruning of the blood vessels. We did an angiogram for this, and this is what we see. This is a case of a classic trichiosis disease where you see a peripheral dropout which cannot again be picked up with a standard angiogram. Another case, this girl had a thicical eye following a VR surgery in right eye, and she came for a routine follow-up of the left eye. Clinically, even to a person with 25 years experience, we thought that the fundus was normal. And yes, of course, the fundus was normal, but we are more suspicious, and sometimes a high index of suspicion is important. And we advised her angiogram, a wide field angiogram, where you could pick up multiple lesions in the periphery. Those are angiomas, and she was diagnosed to have VHL, which underwent a treatment with lasers, and we could follow it up. Father was again asymptomatic. Again, clinically, it looks normal fundus photography, and an angiogram, you can see multiple angiomas in the periphery, which can only be picked up with wide field. Brother asymptomatic, and again you see the lesions. So this is how sometimes if you pursue the patient and the family, if you have a high index of suspicion, you can pick up lesions, and with the aid of this instrumentation you could do the thing. We did a genetic study, and we could pick up the thing. Now this is 38 years female who had blurred image, and you can see a case of a classic VKH. How do you differentiate with a multifocal CSR for the postgraduates there? Look at the choroid, which is very silent, multiple cyst, and the fluid over here is more proteinaceous. I will just run through the last 2-3 slides, and you can do a wide field angiogram which shows you a starry sky pattern classically, which cannot be picked up on a standard photograph again. And these are some of the things. Another case where you see multiple blisters on a single photograph giving you classic topography of the whole eye, and you can pick up that what the disease is. You don't have to look at the disease and try to collate in your brain. So this is how it helps you. And now this is patient who was diagnosed to have night blindness, probably loss of vision, diagnosed as a case of a CRAO. But when we did a wide field photography, this is retinal pigment, retinitis pigmentosa along with CRAO. Now 1 month old baby where you cannot view the fundus adequately, flying baby position, you did ultra wide photography, you can see retinoblastoma lesions, multiple lesions, and you can document and show it to the patient. This is again one of the cover pages of one of the ophthalmic journals where you see a triad of leukemia, where you see in a single photograph metastasis, infiltration, as well as rod spot, which is rarely seen. And we were the first person to make a diagnosis of leukemia rather than the physician referring it to us. Now last
Prashant,
case.
please conclude.
Yes, sir.
Please.
So this is 16 years old male who had diagnosed to have Berlin's edema. And when we told him you have a horseshoe tear, he was reluctant, he was not ready to accept. You did a wide field photography and you could pick up this horseshoe tear, and he we could convince him. So in short, wide field photography has added a new dimension to us. In fact, we in a routine standard photograph, we make the diagnosis based on only 70% of, means 1/3 of the retina is only visualized. While in this retina exists 220 degrees, so visualization in the periphery can adapt to your diagnosis and challenge the pathophysiology which you were aware of. Thank you.
Okay, Prashant, thank you very much. It could have been little bit cut short so that we could have asked questions. Still, I asked 2-3 questions. One is the peripheral PCV. Once you diagnose, what is your treatment approach?
In this particular
Peripherals. Yeah. Will you stick to anti-VEGFs or you combine with something else also in peripheral PCV? In your first
Shall I
case.
answer?
First
Yeah.
case, yes.
I went ahead with, there were large mounts. I just went ahead with anti-VEGF. Brolucizumab was the only monotherapy
Once
which I used.
regresses, will you do anything extra?
Yeah, if need be, I might go for triple freeze.
Yeah, peripheral cryo, once they regress, probably will help in resolving it for a long run. The second thing is PDR, FEVR. Would you do anything extra than what you described in the case?
PDR or?
With FEVR, the peripheral ischemia is there and you diagnosed it as case
Yeah,
of
correct. We did
FEVR.
a targeted laser in that area.
Yeah. Actually, you need to add up with a belt buckle so that peripheral traction means FEVR is very prone for high contraction, and in long run it will be a tractional RD which will be very difficult to treat. So always add additional.
Yeah, it was
belts.
just 2 clock hours which could be followed up.
No. I am just suggesting you. And the third is severe CNP areas. In his case, like Malta's, where peripheral ischemia is there, always look for systemic vascular insufficiency, be it say dengue or carotid blocks, 90% blocks, all these things can be there. Look beyond the eyes in these cases. With this, I invite our moderator, Dr. Gopal Pillai from Kerala. He's again another dynamite, right? Dynamite. He will be speaking. 2 talks are there. One is sponsored talk, that is learning from recent epilepsy trials, and second one is medical retina registry across first government sponsored clinical trial network.
Yeah,
Both
so
the talks he will speak in 10 minutes.
I'll try. So first of all, let's go to the clinical trial network based registry. This is like the NBM of the BIRAC has sponsored this, and these are the different sites. The Kerala, Bihar, Assam, Madhya Pradesh, Maharashtra, all these places have that. And overall goals of the network was to capacity build and do registry and to start clinical trials extra. I'm just pressing the registry data here. It's a 1.5 years data. And primary diagnosis, you can see that there was about 5,400 people in the medical retina registry. And as you see, 68% of them were diabetic retinopathy, and then BRVO, ARMD, and CRVO. CRVO is the least common. Total number of subjects with primary diagnosis across all the centers, you can see that diabetic retinopathy is the predominant medical retinal disease, medical as well as surgical retinal disease in all these conditions. You can see that. Now, comorbidities wise, this is very interesting statistics. This is the difference between rural and urban. You can see that Chitrakoot is fairly a rural area, and you can see the amount of people having coronary artery disease 4%, CKD 4%, dyslipidemia 1%, as compared to, you look at Kochi, 26%, 17% and 45%. In Kerala, the other place is an RIO, which is like the government center, which also has a significant hypertriglyceridemia. So you can see that comorbidities is very significantly affected by where you reside. Alcohol and tobacco history also, you can see that there are large number of people who have both. Now let's come to the ocular history. Most of them have a decrease of vision. Now, best corrected visual acuity. In most of these places, people presented with initial visual acuity, which is a lot of patients presented with low visual acuity. All right. Diagnosis wise, this is the differentiation between the diabetic retinopathy: mild, moderate, severe, very severe. There are a lot of people presenting with PDR in these areas which are hospital based. This is not population based registry. So many of these referral centers have significant proliferative diabetic retinopathy, and out of which a lot of them, 22% present with vitreous hemorrhage and 10% present with traction retinal detachment, which means that most of the diabetic patients come to us who can actually make a difference quite late in their problem. So this is a type of diabetic retinopathy center wise. All centers it is like this. Now we can see that in BRVO, non-ischemic is like 60% and ischemic is about 25%. And these are the center wise, and in CRVO you can see almost 40 and 50% ischemic and non-ischemic. All right, so in BRVO there is a lot more non-ischemia. These are all real world results. And type of AMD as well, wet AMD, there will be a lot of patients with actually classical rather than occult. Now let us look at some of the biomarkers. Okay, predominantly classic, minimally classic, and occult. So predominantly classic was more common in all the sites, and occult was 20% only. These are center-wise distribution. In diabetic retinopathy and in RVO, there was ischemia in about 25% of people in diabetic retinopathy, but in CRVO the numbers were fairly higher. And NVD was seen in about 14% of patients in DR versus 8.14% in CRVO. Now let us look at the follow-up data. All right. So visual acuity improved significantly. You can see that in CRVO, 0.69 improved to 0.57, and BRVO 0.41 increased to 4.33, which is a significant improvement, more than 2-line improvement in vision. In AMD as well as DR, the total visual acuity improved, but not as much as in BRVO or CRVO. These are about 2,750 eyes which are followed up. And this is the improved status quo and worsened. If you look at it carefully, about 80% of people have static or improved over a 6-month period. Worsening is also seen in about 20% of people. So in real world, there will be, we will not be giving injections as per in a clinical trial, and we know that there will be a 20% people who actually worsen, and these two are the people who have improved or remained static. Now this is the change in logMAR in different visual acuity conditions: improved, worsened, and net change, which I already said. Now these are the change in logMAR as against the treatment process. You can see all injections, all medications, all are showing a positive logMAR, but laser is showing a negative logMAR, but that is because some of these post-laser patients will bleed because of proliferative diabetic retinopathy, and they will skew the results against the improvement. Thank you very much. I finished in about 5 minutes.
Great. That's why I called you dynamite.
So, so next would be 8 milligram. So this is a recent trials in aflibercept, and this is 8 milligram is like 8 milligram in 70 microgram. Currently we are using 2 milligram. So here we have 4 times higher molar dosage. So the molar dosage concept brought in by brolucizumab as well, because brolucizumab has higher molar concentration, and now 8 milligram has much more molar concentration, 4 times more molar concentration than aflibercept, which itself is a very good drug. So Photon trial evaluates the DME, and Pulsar trials evaluates the AMD. Now these are the 1:1:1 randomizations. 2 milligram every 8 weeks, or maybe 2 months I would say, and 8 milligram every 3 months, and 8 milligram every 4 months. So this was a head-on-head trial between 2 milligrams on a 2 monthly basis versus 8 milligram on a longer duration basis. Now let us look at, this is the dosing schedule as I just told you, and if there was worsening, there could always be shortened injection. That rescue was also available. Now you can see that almost equal number of people were into the study, and baseline demographics wise everything was almost equal. Baseline characteristics of the study eye was also almost equal, and you can see that 2 milligram given every 2 monthly had a slightly better visual results, but it was not statistically significant. It is almost equivalent to the primary endpoint at 48 weeks was met in both the 8 milligrams group as good as the 2 milligram group as well. So this is the key secondary endpoint, the proportion of patients without retinal fluid. You can see that about 60 to 65% in the 8 milligram group had no retinal fluid at week 16. Now proportion of patients maintaining 3 monthly or 4 monthly week intervals, it's very high, about 80%, 77%. That's an average of about 83%. This is a central retinal thickness. You can see that all the worms are almost traveling together, and 2 milligram every 2 monthly, which is the current best, is also achieved by a 3 monthly or a 4 monthly injection of 8 milligram. So side effects, intraocular pressures, cataract, retinal hemorrhage, some of them, but they are all equal. There is no significant intraocular inflammation or anything like that. Non-ocular safety side effects, the acute thromboembolic events were more seen in the 2 milligram 2 monthly as compared to the 8 milligram 12 weekly or 16 weekly. Now pulsar key secondary endpoints at 8 milligrams at 3 months and 4 months had complete non-inferior visual acuities, and it had superior drying as compared to 2 milligram every 2 months, and ocular and non-ocular safety was comparable to the 2 milligram group. So pulsar results, this is in a nutshell: 79%, 77% had maintained 3 monthly and 4 monthly injections. Photon is the similar study but in diabetic macular edema. 2 milligram 2 milligram 2 monthly, 8 milligram 3 monthly, and 8 milligram 4 monthly. Okay, 1:1:1. All the baseline, these are the all the baseline characteristics and demographics. Everything was the same. Prior treatment was also the same. These are the worms, almost equal. You can see that 9.2 letters, 8.8 letters, and 7.9 letters. There's hardly any difference between the three. All right. So large majority of 8 milligram patients maintained randomized intervals without change. They need not have changed to reduced frequency of, increased frequency of injections. Most frequent ocular adverse event wise, cataract, conjunctival hemorrhage, intraocular pressure, all these were almost similar in each. There was 0.6% and 1.2% intraocular inflammation, and non-ocular safety was also all right, in the sense 3.6% of people had thromboembolic events as compared to 2.4 and 4.3 in the other groups. So primary endpoint in both the 8 milligram groups were met. It had non-inferior visual acuity as compared to 2 milligram 2 monthly in diabetic macular edema as well, and side effects were also comparable to the current gold standard. Now this is like 90% of persons, 93% of patients could have been maintained at 3 monthly injections, which means with both photon and pulsar, we understand that these patients will receive 4 injections in a year, which is a very, very important step in improving compliance, in making patients happier, so that then with the number of injections lesser. So this is a brief summary. Week 48, aflibercept 8 milligram had non-inferiority in visual gains and almost equal side effects without nothing more. And again in DME with photon, non-inferiority in visual gains as compared to 2 milligram 2 monthly. So these are very good drugs which are coming in, and probably we will start using these drugs in about a year's time. Thank you very much.
Thank you very much. Actually, he finished in record time. Actually, I should recommend to the Guinness.
So we will have some discussion, sir.
Yeah, that's what I'm ready with now. Okay. So you said it is in the government-sponsored clinical trial. how did you define ischemic and non-ischemic BRVO, and what are your definition criteria
Yeah.
for both the conditions?
The ischemia in BRVO and CRVO were defined as according to the BRVO and the CVO study, sir.
Studies, but there they have done the angiography
Yeah.
and they have seen the
We have done.
CLP
We
area.
have taken only those patients whom angiography has been done for looking at that biomarker.
Okay.
Not all BRVOs and CRVOs will go through full angiography, but we have taken only those. Yeah.
Okay, means small part of it is included in that.
Not small, about 50%.
Um, so I just want to renew my knowledge. How much disc diameters did you take in case of BRVO
5,
and CRVO?
10.
What is the percentage of ischemic BRVO
About
gone into
25%.
neovascularization?
Percentage of BRVO with neovascularization. Sir, the study, the follow-up, the first follow-up was basically at about 6 months. So I think
By that time,
the
nothing
neo-
has happened.
Yeah, neovascularization has not happened yet.
Yeah,
So,
because this is
yeah.
$100 question
Yeah.
per week.
Yeah.
Probably you people not have noticed this because they do a lot of research in Alvi Prasad. So please address this. BRVO, we still not definite that this is the area of capillary non-perfusion that will lead to a neovascular process. Really, it is an enigma, but yes.
Yeah, but what I have
theoretically it is
noticed,
ischemic
sir,
and
is that
non-ischemic.
the BRVOs which don't have any decrease of vision, which means nasal or some other area where macula is not at all involved, they don't come to us.
we are,
Those are the patients who generally develop a neovascularization. The ones in which macula is involved, we will inject, we will follow up, we will
Do everything,
Yeah.
yes.
So those are patients whom neovascularization may be less. I mean, we will pick them up early also. Yeah.
Yeah, yeah. No. See, the thing is, I have one patient, at least one or few, maybe 2, 3, not many, but where I have done the laser also. Then they come with vitreous hemorrhage because of development of neovascularization. When I look back and see how much area of capillary non-perfusion is, I think only peripheral small area is there. So the definition of 5 disc diameters is not a foolproof, and it requires a research. Okay, that's why I given it to Bhavik. Okay, next is AMD. You said classic is very predominant, which is surprising to contrary to my clinical this thing. Majority of my clinic now I am seeing more occult rather than classic.
The classics
So how
are
did it
usually
happen in
managed
your
by
study?
lesser experienced people, sir.
But
and
I don't
by
think
the
you are
time
a
they
lesser
reach you,
expert.
it will be the occults which will come to you,
I
which I
always
have
looked
missed
at-
probably.
No. I always looked at you as most experienced. Okay. No problem. Okay. And you said visual improvement you have seen on follow-ups. What treatment recommendations did you give in these three
These are
conditions?
real world, sir. So right from Regional Institute of Ophthalmology to rural areas to, so this is a mix of all the patients.
Yeah, but no.
So
that slide
about
showed
20% of patients actually, 20 to 25% of patients actually improve in vision.
I'm interested in these audience. Okay,
Yeah,
I'm batting for them actually.
Yeah,
When
yeah.
they read that,
Yeah.
what should they infer?
Yeah.
Just tell me
So
in
with
one
medical,
sentence.
so with real world medical retinal management also, about 70% of patients will have stabilized or improved vision, and about 20 to 25% of patients across diabetic retinopathy, AMD and BRVO will reduce vision.
One thing I
Probably
want
with
to
a
infer.
clinical trial thing, it may be a little better, but in real world, this is what is happening in 6 months.
Yeah, shall I infer from on their behalf, and then you correct me if I am wrong. Okay, with the conditions like BRVO, CRVO, and DME, and classic CNVM, with interventions. Okay, I'm not defining what is the exact intervention, but intervention likely to have a better vision compared to the other people. Am I correct?
Yeah, absolutely. But
So that
but
is the
that is
inference
not
we need to take.
that is not translatable from my study because we have
Definitely.
intervened in all the patients.
That's what I'm saying.
Yeah.
That's why I'm saying
Yeah.
appropriate intervention, we can save their vision better than
Absolutely.
the other patients.
Yeah.
Okay, that is over for the first talk you given. The second talk, which aflibercept we all know, okay, because there are few people whose faces are very familiar. They are standing behind. But we are know that aflibercept is a good agent. It is lasting for 5 weeks or 6 weeks. Now you have increased the potency 4 times. And if you are saying that it is beneficial by 10%, 20%. Okay.
10%, 20%.
Yeah.
Better.
Better, no? 6 weeks to 4 months. It is, you are saying, claiming of 50% of the patients.
No. Let me make it a little more
Clarity. I am not clear about
Sir,
it. Yes.
2 milligram is what we use now, and in the one arm was 2 milligram every 2 monthly.
Yes.
The other two arms was 8 milligram 3 monthly or 8 milligram 4
4
monthly.
monthly. Yes.
They are all comparable.
Yes.
So you have reduced the number of injections from about 6 injections in a year to about 3 to 4 injections in a year. This is the advantage.
6 to 3.
3.
That is double the effect.
Yeah.
And another thing which you palmed off, probably in the speed of completion of the presentation, your cardiovascular risk factor, non-ocular risk factor, cardiovascular MI, is 2 milligram 2.6 times, and 8 milligram is 4.3
It's in which study,
times.
sir? AMD or DME, sir? Which you looked at?
You
I'll tell you,
see
sir.
the
Yeah.
systemic effects of this thing.
Yeah,
aflibercept.
Yeah.
2 milligrams is 2.6 and 8 milligrams is 4.3. Means the risk is doubling.
Okay. So let me just
How
put
should
that.
I take
no,
it?
let me just put it here. Okay. In the AMD, which is predominantly older patients.
Yes.
Okay. Who are not. I mean, many of them may not be because diabetic retinopathy means all are diabetics. Here, it's an old age group. 2 milligram 8 weekly has about 1.5% thromboembolic events, as compared to 0.3% in the 8 milligram group. 1.5 in the 2 milligram 2 monthly versus 0.3.
How is it possible?
Because more than the molar concentration, maybe it is the frequency of injection which is more. I cannot explain all that, but I'm just postulating. All right. Now coming to diabetic macular edema. Now coming to diabetic.
No, I'm interested in discussion, but I want Mallika to speak and then I will listen to her. Okay. Thank you very much for enlightening so much. And you given extra time, but he is scolding me.
Good morning, everyone. Thank you for this opportunity. Okay, so I'll start with the approach to retinal vein occlusions, and I will stick to mostly practical points. So when we see a patient of retinal vein occlusion, the first thing to look for is what is the underlying etiology, rather than treating the eye alone. So we must investigate for hypertension, diabetes, lipids, tobacco use, very, very important. And in younger people, homocystinemia, blood malignancies like leukemia, and inflammatory causes. Then what to look for in the eye? Very, very important to look for glaucoma, because these are very commonly coexisting problems. Very easy to miss the optic nerve changes. So be very high index of suspicion, and if there is glaucoma, avoid steroid intravitreal injections because the risk of IOP rise is higher. Similarly, the glaucoma doctor should avoid using prostaglandin analogues or alpha agonists for glaucoma management, because that will aggravate the macular edema caused by retinal vein occlusion. Classification depends on the occlusion site, central, hemiretinal or branch. Each of these can be ischemic or non-ischemic, and in branch vein occlusion it can be a major vein or it can be just a macular vein. Ischemic CRVO and HRVO, those present with extensive hemorrhage, poorer vision at presentation, severe macular edema, very poor visual prognosis, and higher recurrence of macular edema with requirement of injections. Sometimes, in fact, the ischemic CRVO may not present with much of macular edema, but it goes very rapidly into macular ischemia, as you see on the other slide. In these cases, very high vigilance is required for neovascularization of the iris. In non-ischemic CRVOs and HRVOs, the prognosis is much better, fewer injections with very good visual outcomes. HRVO falls into shares the clinical features of both BRVO and CRVO. So we have to extrapolate the treatment strategies as from the studies pertaining to both these conditions. But this is more prone for neovascularization of the iris and glaucoma, unlike BRVO. So vigilance for this is important. In macular vein occlusions, the treatment for macular edema remains the same. The only relief is that the risk of proliferative retinopathy is not there because there is not extensive ischemia. So this is a big relief. Now RVO, one we have already discussed, is the problem of macular edema or ischemia. Also, like diabetes, it can develop neovessels on the retina or on the disc. So every evaluation, follow-up evaluation, we should look for neovessels on the disc and elsewhere. But most specifically, we have to be very careful about NVI and NVG. Every follow-up, look at the iris undilated for CRVO and HRVO. And if required, do a gonioscopy if the pressure is borderline high. And the risk increases when we stop injecting anti-VEGF injections for macular edema. So after 2 years or 3 years is when the risk of neovascularization iris or glaucoma starts, because that's when the macular edema is gone and we stop injecting. Even non-ischemic cases convert to ischemic, so we should not be complacent in non-ischemic CRVO and HRVO. They can convert. Hard exudates in retinal vein occlusions. These are more damaging than fluid. They cause permanent foveal damage, and it takes more aggressive therapy to clear these compared to fluid. Requires more closely spaced injections. So it's better to prevent these if possible. As you see in this slide, within 3 weeks, a hard exudate has moved into the center, which was not there. So we have to be very quick in our treatment. This is a patient, vision is 6/6, but he has symptoms. And you see the hard exudates are still not right into the center. So preventive treatment was done. Angiogram, followed by an injection, followed by laser for more permanent effect. A lady who got 6 Ozurdex elsewhere for foveal exudate, we did an angiogram so that we know where is the leak. Then we gave aflibercept single injection followed by laser, and within a few weeks, 2 months, you see it's cracking up. The exudates have begun to dissipate. But if you don't treat aggressively, just one aflibercept given in 4 months, then the exudates are increasing. Fluorescein angiogram is not routinely required in vein occlusions, except when we want to do laser for the macular edema, because leakage is not shown up as OCT angiogram. OCT angio can otherwise pick up NVD, hypoperfusion, ischemia, as well as NVE if it's a wide angle system. First line of treatment remains anti-VEGF injections for macular edema. And which anti-VEGF injection? These are various studies which have been done. SCORE 2 showing aflibercept showing much more beneficial effect than bevacizumab. LEVO study showing that much fewer injections required with aflibercept than with ranibizumab, with greater anatomic improvement. Another study, the Newton, showing that in cases that recur very frequently, aflibercept can increase the treatment interval from 5 weeks with ranibizumab to 9 weeks, and further improvement in vision and anatomic improvements are also seen. So reduced treatment burden with better results. So when do we use steroids for RVO related edema? And only when anti-VEGFs are contraindicated, such as pregnancy, which is an absolute contraindication. Others are relative contraindications, recent cardiovascular problems, significant nephropathy, or when there is active neovascularization with traction. There anti-VEGF can cause worsening of traction. So there, if you have an edema, you might want to use a steroid. Suboptimal response after 3 to 4 anti-VEGF injections, but I do not find that with the newer anti-VEGFs that's a benefit. And planned cataract surgery possibly. When do you avoid steroids? When there is a known glaucoma, or the patient is immunocompromised for any reason because the risk of infection is higher, or there is a large PC opening or a scleral fixated IOL because the implant can move to the anterior segment, causing an emergency corneal decompensation and glaucoma. The role of laser in retinal vein occlusions is definitely established for branch vein occlusions. It gives a long-term response. So initial injections reduce the thickness of the macula, and then based on the fluorescein angiogram, laser should be done to have a long-term effect. In CRVO, there is no benefit for macular laser, but definitely scatter laser has to be done for all categories when they're required. Every follow-up, close evaluation of the iris and angle. And this is just to show how a patient, despite all treatment, goes into NVG. If there is a disproportionate amount of vision loss in a CRVO, there is possibly macular infarct from associated cilio-retinal artery occlusion, as you see here. However, injections still work, anti-VEGF still work. And this is the last slide. Retinal vein occlusion in the young, usually caused by inflammation. Look for blood malignancies like leukemias, homocystinemia, And in males, look for sildenafil use. In females, oral contraceptive pills can cause it. These are usually good prognosis, 1 or 2 injections, and they get back very good vision. Thank you.
Thank you, Mallika. See, I have one clinical doubt. If you see between all the vascular occlusions, the tributary BRVO somehow it appears small, but the most resistant. I
Yes,
see most
yes.
of the long-lasting this thing. What is your first treatment of choice? Injections. Which injection would you like to give
In tributary, in macular vein occlusion.
with macular edema?
Well, I use aflibercept because that has least side effects and maximum efficacy and durability.
What is your experience about brolucizumab in these cases?
I've never used brolucizumab because I do not want to have inflammation and problems. You know, you cannot make a patient worse than when he came to you.
Did anyone use brolucizumab for tributary BRVO in the panel? No. Okay.
It should not be used as
I-
first line
I
anyway.
think,
As first line, it should not be used anyway.
Thank you. Okay. Now we will move on to Dr. Bhavik Panchal. He's a local guy from LVP Vizag, and he will be speaking on review of artificial AI in ROP, diagnosis and prediction of treatment.
Yes, so
Dr. Bhavik.
good afternoon everyone. I'll do it from here. No, this is not the presentation. I'll do it from here. So good afternoon everyone. This will be a short talk in terms of review of artificial intelligence, not just in ROP, but a brief overview of artificial intelligence in general. So I have tried to keep it short and not going too much of algorithms because that requires a little bit of learning of AI as well. So AI or artificial intelligence refers to software that can mimic the cognitive functions such as learning and problem solving. So the problem here is detection of ROP, screening and treatment of ROP, right? And same applies to DMA and EMT as well. So basically here the idea is to augment the already existing protocols and the treatment aspects and not to replace them. This is a big misconception that AI is going to replace doctors or treatment modalities. It is mainly to augment, right? So simplify types of AI. It can be simple automated detectors, okay, like whether this disease is present or not, plus disease is present or not, okay, looping is present or not, are just simple examples of automated detectors that can work. Machine learning is a subset of AI, that is artificial intelligence, which is a little advanced form where you don't need a much larger subset. A smaller subset that is in the form of images is good enough for us to understand and detect based on the program or the algorithm whether the disease is present or not. And third thing is deep learning. That is again a subset of machine learning itself, which is based on a lot of artificial neural networks. It's just like how a brain works. Okay, one such example is driverless driving or driverless cars. That is purely based on deep learning. So as I explained, artificial intelligence is the largest subset. Within that you have the machine learning and artificial neural networks, and you have the deep learning, right? So yes, AI has made a significant advancement in the field of ophthalmology, and something called as disruptive innovation in healthcare. That is what AI is driving us forward. How it works? Image analysis, yes. Dose optimization, especially when you have to inject a drug, say for diabetic patients, right? For everyone need not require a 0.05 ml. Some may require lesser drug or larger drug. That can be personalized. Attention can be given. Treatment recommendations can be made. Data integration, decision support. We are talking about 4 monthly follow-up, 3 monthly follow-up. For ROP, does every child require a weekly follow-up? No. So this individualization can happen in this. Disease risk prediction. I have a child who is born at 32 weeks, but what about the weight? What about the hemoglobin and thrombocytopenia is present or not? Right? The patient had a neonatal sepsis or not? Received intravenous drugs or not? Based on all this entire subset, we can predict a model, maybe from the maternal factors as well. Can this child who is going to born preterm will develop ROP or not? This is what we are looking at with this kind of AI network. So coming to the talk per se, current diagnostic procedures involve a series of eye examinations and image capture, and these images are then seen by someone else and detected whether this is basically a teleophthalmology model of current what we are doing in ROP screening, that someone else is screening, technician is screening the eyes, and we are sitting at the center and assessing whether you have ROP or not, right? So this relies on is time consuming, relies on interpretation of human experts, and human errors can also happen. So AI has potential to improve the ROP diagnosis by providing accurate and efficient analysis of retinal images. You don't need a human factor here. Run the images, it will pick up and it will inform you whether the this child has ROP or not, or in the next 2 weeks, next 1 month, this child will develop ROP or not. Okay, so already a lot of literature is there, especially from the Western media, where machine learning and even deep learning algorithms are used based on the vascularity score index and from the pupil diameter as well. This is just few biomarkers which are available for them. So automated ROP detection systems are there. AI guided laser therapy also was once in a time people started doing that. Okay, what if we do a selective laser and which areas need to be lasered? And risk prediction models, as I explained, pre-delivery and after delivery as well, which child may go and develop ROP. So we have a lot of companies which are already started in this domain, Path AI, NVIDIA, you have iROP as well. So as I explained, flush disease is a very important factor here that can be picked up by AI. So this is just a table here, a very good review article which explains the several neural networks. As I explained, the algorithms, this is beyond the scope of this talk here to go into the algorithms per se, which is image based, also which is based on data, right? So deep learning networks is very precise, very accurate, but it requires a larger amount of data. But with a smaller amount of data, machine learning can be used. So which we can devise our own tools on the software, on a mobile phone, which we can use to predict the outcome or the screening aspect of ROP. The important aspect here is of the cost analysis or cost effectiveness of artificial learning. Again, a lot of literature has been done from especially Peter Campbell and Ryan Paulchen. They are very big pioneers of ROP in USA, and they have shown that yes, definitely it is cost effective if at all. The initial setup requires a lot of cost, but once it is set in, it is much more cost effective. So to finish, advantages are improved efficiency and accuracy of diagnosis, reduced need for specialized expertise, right, and improved risk prediction in this. And last, limitations are, yes, there is a lot of bias with any technology. There's a term called as garbage in, garbage out. A lot of images will not be processed. That will also give us false information. It is important to understand which image actually is true or not. Okay, limited generalization, lack of explainability. We do not have explanation. Sometimes you have pictures of lot of dogs in between, you put a picture of a wolf, it's not going to identify, right? So the explanation is a problem. Cost and infrastructure, obviously. Future directions, new and innovative AI powered systems for ROP will predict the likelihood of an infant developing ROP from the maternal factors as well before the delivery to happen, and AI systems to guide the treatment of ROP, how much of dosage, when the drug should be injected, when the follow-up can happen, all these things can be taken care of. So to conclude, AI definitely has a transformative impact. As I mentioned, this is in direction towards a disruptive innovation in healthcare. So thank you so much.
Thank you, Bhavik. Actually, we are short of time. Already Karnia people are listening the Retina talks very painfully. So we are moving on to the last talk. I will not do my talk. And Lohit, I requested him to finish the, he is also again local guy from Vishakhai Hospital. That's why I didn't venture to stop him. Again, Lohit, I request you to finish in 5 minutes, and we will be giving the session to you in 5 minutes time. We are late by 5 minutes. Please excuse us. I have given up my talk of 7 minutes.
Good morning, everyone. I'm talking about, I'm Dr. Lohit. I'm talking about ILM Forces, new innovator from the Alcon company. So I'm using some of the slides from the, it's not moving.
Audio visual. The slides are not advancing. Yes.
So I'm using some slides and clippings taken from the Alcon Academic Limited. Internal limiting membrane is a basal lamina of inner retina, acts as a cofold for proliferation of fibroblasts. It has a crucial role in structural integrity. The ILM peeling removes tangential interaction on lateral layers. It can cause subclinical damage to the RFL fibers. It is intrinsically related to the nerve fiber layer with convoluted margin. Advantage of ILM peeling is reduce the recurrence of epiretinal membrane and the closure of large macular holes. ILM forceps, the previous 25 gauge, the initial grasping to create an edge in the ILM peeling, that is a used technique of pinch peeling. Chances of retina trauma can be present and amount of force applied to the grasp cannot be controlled. The evolution of the technique. In the current procedure, friction injury by indentation, we can see that in the top image, there are normal force and indentation force applied in the previous forceps. In the new concept, friction injured by the surface adhesion by titanium, we can minimize the area of the indentation and force also. The Sarskin forceps, it is available in 25-27 gauges. The surface coating was done by the with titanium. Laser ablation using specific patterns, 10 into 10 into 5 micro teeth pointed towards grasping edge at 30 degrees. This is a video of the Alcon showing the video regarding the ILM forceps, Graceberger 25 Sarskin forceps. This is new forceps with laser ablated structured blade with 10 into 10 into 5 micro teeth present. We can show that it enhances kinetic peeling, minimize the friction, the conformal grasping platform shape present there, which helps in indentation, decreasing the intent force. With the help of grasping gauge, we can actually feel the ILM. So this is available in 23, 25, 27 gauges. 25 and 27 are better. So one we have gone through the ILM and we have the instrument. Now we have to now we are going for the vision system. Digitally assisted vitrectomy surgery, Ingenuity, 3-dimensional head split display system, heads up display. 3 components are there: 2 1080p cameras, processing unit, and 55-inch 4K display. VR surgery is performed by looking at the skin with passive Polaroid glasses. Different filters to enhance visualization of various structures. The postulated benefits are improved ergonomics, minimize the back and neck pain in vitreous surgeries, and reduce phototoxicity. Color filters to reduce the quantity and duration of the eye exposure. Digital magnification with high resolution. Macular surgeries without flat lens also. It is a beautiful teaching tool. Observers see image as the same image as the surgeon, that too simultaneously. This is my experience in the Ingenuity in our center. We can see the residents and fellows seeing the operation. It is another video of my experience. In the interlimiting peeling, video of vitreous hemorrhage case where I am peeling the interlimiting membrane. In this video, you can see that I am grasping the ILM and I am able to see feel the I am able to feel the membrane actual ILM. Even there is a retina touch there that was not bleeding heavily, which doesn't need the cauterization. In this procedure, I am trying to peel the ILM with precise manner because of the grasping pattern. In a single go, we can remove the interlimiting membrane. With the multiple attempts also, I can still feel feel the depth and the stereopsis, how to hold the interlimiting membrane. With the centrifugal force, I have removed it. So what is the challenge? Contact lens versus non-contact lenses. Initial grasp will be the epicenter of the striae. Peeling motion is similar to the rexis, like a circular and tangential. With the help of newer Sarskin forceps, we can avoid flex loop and other loops, so that we can remove the ILM, feel the ILM while removing the ILM. Which now ILM forceps having an atraumatic design with the precision and a grasping. This is a finest Sarskin ILM forceps. Atraumatic design featuring laser ablated microstructures, surgical precision delivered through conforming grasping platform shape. With 27 gauge grasping platform, it has improved grasping ability. It is a design for performance. The laser ablated microstructures are engineered to enhance the kinetic friction. As I mentioned, it is 10 to 10.5 micron teeth pointed towards the grasping edge are designed to grasp the intended retina tissue to improve the coefficient of friction so that we can minimize the actual force on the retina and easily facilitate initiation of ILM peeling and reduce trauma to the retina and mediate membrane shedding. Shaped for precision, an adapted grasping pattern and angled tip closer enable grasping precision. The forceps reduces the indentation force to grasp by 50% and reduce repeated grasping and conform to the curvature of the retina and twofold grasping ability. A larger platform is designed to improve grasping ability. 27 gauge decrease the closal angle of the forceps and increases the length of the grasping edge, which is required for the larger MAC holes or the recurrence of ERMs. Thank you.
Thank you. Actually, yeah, we came to the end of this session. Thank you, Lohit, for the nice presentation. Thank you, Dr. Chandramohan and our friend Gopal Pillai. And thank all the cornea surgeons who are patiently waiting for the session. Though you are all seeing at the mobile, that is not advisable. You should have listened to Retina talks. I know.